This recording will go over Kawasaki disease. Kawasaki disease is an acute febrile exanthematous or illness that causes skin eruptions of children involving generalized vasculitis of unknown etiology. Kawasaki disease is a major cause of acquired heart disease in children in the United States. The cause of Kawasaki disease remains unknown. Kawasaki disease is seen most frequently in children younger than 5 years of age and is diagnosed less frequently in children older than 8 years of age. Affected boys outnumber affected girls, and there is an increased incidence of children of Asian ancestry. An infectious or possibly toxic trigger initiates an immune system response that affects medium-sized arteries, especially the coronary arteries. A generalized immune response becomes more specific, with increasing numbers of T lymphocytes and B lymphocytes infiltrating the smooth muscle cells of the vascular walls. The infiltration causes edema and inflammation, which progressively weakens the vascular wall, leading to aneurysms. As the disease progresses, fibrous connective tissue forms at the inflammatory sites, eventually thickening and scarring the vascular walls. These vascular changes, along with increased platelets that occur as a result of the disease process, can cause thrombus formation, myocardial infarction, and death in some children. Kawasaki disease manifests in 3 phases. The acute stage lasts approximately 10 days and is characterized by a high fever that persists longer than 5 days. The fever is unresponsive to antibiotic treatment. Clinical signs include bilateral, non-purulent conjunctivitis, changes in the mucous membranes, such as erythema, fissures, and cracking of the lips and strawberry tongue, changes in the peripheral extremities, such as swelling of the hands and feet, and erythema of the palms and soles, and generalized erythematous rash and enlarged cervical lymph nodes. Tachycardia and extreme irritability are also common. The second or subacute phase lasts from approximately day 11 to day 25. The fever disappears and most symptoms resolve. The phase is characterized by continued irritability, anorexia, desquamation of the fingers and toes, which is peeling of the skin, arthritis, arthralgia, and cardiovascular manifestations, including heart failure, dysrhythmias, and typical coronary aneurysms. Coronary aneurysm formation begins early in the second phase, with 20% of patients affected. A baseline echocardiogram at diagnosis with repeat studies at 2 weeks, 6 to 8 weeks, and 6 to 12 months will help identify those with coronary artery involvement. The final or convalescent stage begins with most symptoms have disappeared and lasts until the ESR returns to normal. Deep transverse grooves called bow lines may appear in the child's nails. In regards to diagnostic evaluation, fever of 5 days duration in conjunction with at least 4 of the 5 following primary clinical findings for the acute phase establishes the diagnosis of Kawasaki disease. The 5 clinical findings for the acute phase include bilateral non-purulent conjunctivitis, oral mucosal alteration, redness of the hands and feet followed by desquamation or peeling, rash on the trunk, cervical lymphadenopathy with large nodes, no other known disease process to explain the signs and symptoms. Lab data is nonspecific. The white blood cell count is elevated during the acute phase, as are the ESR and C-reactive protein levels. There is sterile pyuria. The ECG in the acute phase may demonstrate first-degree heart block. Platelet levels dramatically rise during the subacute phase. Aneurysms are detected with an echo. Therapeutic management is directed towards preventing or reducing coronary artery damage from Kawasaki disease. High-dose intravenous immunoglobulin in combination with aspirin has been shown to lower the prevalence of coronary artery abnormalities when given within 10 days of fever onset. High-dose aspirin therapy is begun at the same time. Initially, the dose is in the anti-inflammatory range of 80 to 100 milligrams per kilogram per day in 4 evenly divided doses until fever resolves. The dosage is then reduced to an antiplatelet aggregation dose of 3 to 5 mg per kilogram per day once daily and continued through weeks 6 to 8 of the illness. If coronary artery abnormalities are identified, this dosage is continued indefinitely. Corticosteroids may be considered if the child is unresponsive to standard therapy. However, clear data regarding its administration is lacking. Please review the purple nursing care box for the child with Kawasaki disease.